Good afternoon, everyone, and welcome to the last grand rounds before the Thanksgiving break. We have a few more grand rounds this year. A very special speaker today, someone who's become a very close collaborator and friend over the past few years. And to many people, I think is a bit of an unknown entity because she lives in the shadows of the education research world that isn't as prominently known to a lot of people in our department. Our speaker today is Dr. Nike Bochetai, who I've known for now a good 4 or 5 years when she first approached me when she was doing her PhD work in sociology at the University of Geneva and looking at conflict and collaboration across different professions in at the time mostly in surgical settings, and she was wondering whether how things were in Geneva was similar as in a different country, and somehow found me and said, would you be willing to help me get some of this research off the ground at UCSF? And I said yes, and that was one of the best decisions I've made in the past few years in the research realm, because she then decided to not only do the final pieces of her PhD work here at UCSF, but to come back for a postdoctoral fellowship funded through the through the Swiss government, and has spent the past 4 years with us doing work on interprofessional collaboration, and being just a tremendous collaborator herself, an outstanding mentor to a lot of educational researchers in the department, as well as outside of our department with people in the Center for Faculty Educators. A very, very clear thinker, and someone who I think if you Google her or do a Google Scholar search, you'll realize really one of the people at the forefront of promoting interprofessional collaboration and thinking about what stands in the way and how can we make it better. She's in addition to completing her PhD, she has multiple publications, including first and senior author publications in the preeminent journals in this field. While her postdoctoral fellowship comes to an end over the next few months, early 2022, I'm hoping that we will have long-standing collaborations, because we can definitely learn a lot from people like Nike. So Nike, welcome. I'm going to hand it over to you so that you can tell us about your work at UCSF and before that you joined UCSF.
Thank you so much. And thank you everyone for being here today. As Sandrine just said, I'm going to talk a little bit about some of what I've learned about first conflict between healthcare professionals, and then how we can hopefully move from conflict to collaboration by focusing on interprofessional relationships in clinical environments. Before we start, I just wanted to say that I don't have any disclosures for today's talk. And a lot of my work is really grounded in a couple of key reports that were published around 1999, 2000, that really showed for the first time that there was a very strong relationship between collaboration, teamwork between healthcare professionals on the one hand and patient safety on the other hand. So reports like To Err is Human in the US, or in the UK, they had a very similar report, an organization with a memory, showed that up to 85% of medical errors were due to poor communication and to conflicts between healthcare professionals. And that really got a lot of attention. And then subsequent reports also showed similar findings, that there was such a strong correlation between poor communication, conflicts, and poor patient care, or errors in patient care. So since then, there has been a growing focus on collaboration and conflicts in healthcare teams. And when I talk about conflicts, I just wanted to clarify that I think about conflict as the perception of incompatible goals and expectations. So it's not necessarily people openly fighting or arguing or disagreeing. It can be a very one-sided conflict, but it's really when people feel like the rest of the team doesn't recognize their goals or doesn't value their goals or their contribution. So it can be very one-sided. Sometimes it's two-sided or has multiple sides, but it's really that perception of having misaligned goals. And when I started my work in this field, what we knew about conflicts was mostly that we tended to view conflict as really negative and something that we want to avoid, even though conflicts are actually can have positive impacts. And the goal is not to not have any conflicts, because conflicts are useful, but the goal is really to use conflicts constructively, because conflicts actually are opportunities to identify disagreements, misunderstandings. And so that really, if we can address those conflicts, it really helps us move forward, improve judgment, improve decision-making. And just if we're able to clarify misunderstanding, it means that then we can all agree on something and move forward together. And there's just more buy-in to the decisions that are made. And so that's basically what we want, because it can lead to improved team performance and cohesion. What we don't want is that very often we don't address conflicts, and that can lead to poor collaboration, poor communication. People don't necessarily trust each other anymore. And that over time leads to higher burnout and staff turnover. So we don't want that. But when I started my work in this field, we tended to focus much more on the negative effects of conflicts. And we really knew a lot about those effects, but not so much about what happens, what creates conflicts. So the first thing I worked on was actually a scoping review, which is a type of literature review. We really tried to understand what we knew about conflicts back at that time. And so a scoping review, for those of you who are not familiar, it's a type of literature review that's a little bit like a systematic review in that it's very rigorous, it has very clear steps. It's different from a systematic review in that it's more descriptive and inductive and open-ended. So it really tries to describe a phenomenon instead of asking a question that we tried to answer with yes or no, for example. So we did this scoping review, and we ended up finding 99 articles that talked about or that described conflicts between healthcare professionals. But what we found is that a lot of these 99 articles had important limitations that really limited our understanding of conflicts, because only 28 out of 99 addressed articles 28 out of 99 articles addressed conflicts as having multiple dimensions, but most of these articles really just focused on the impact of conflicts on individuals without really looking at team dynamics or institutions or patient care. 61 of the articles collected data from one profession only, and very often that was from nurses, even though they described interprofessional conflicts that involved people from different professional groups. So it really just gave us one perspective on conflicts. And 70 out of 99 articles used quantitative instruments to look at conflicts. So that gave us a really good idea of the prevalence of conflicts, and we really confirmed that they happen all the time, that they're very common, but it didn't really tell us much about how these conflicts happen, how they impact people, how they're experienced by people in the field. So based on these limitations, we designed two qualitative studies, and Dr. Van Schaik alluded to them. The first one was a year-long ethnographic research that I did as part of my PhD, where I conducted a lot of observations and interviews at two academic medical centers, one in Switzerland where I was doing my PhD, and one in California. And then I was also part of a big international collaborative study for which we conducted 249 semi-structured interviews with healthcare professionals, and where we asked them to tell us about conflicts they had experienced. For that, I was in charge of the Swiss team, and we conducted 82 interviews in Switzerland. If you're not familiar with it, just semi-structured interviews are a type of interview where we have a couple of key questions that we want to make sure we ask every single person, but we tend to let the conversation happen organically so that we really follow the topic as the study participants want to talk about, so that then we can do systematic comparisons across the data and look at how each person has answered the question, or how each person has talked about a different topic, so that we can then compare and contrast how the different participants answered the questions. So we did that, and our first thing that we found and thought it was important to describe was just the processes of conflicts between healthcare professionals. And we published that in Academic Medicine a couple of years ago. And what we basically describe in this paper is that conflicts can have different sources. And the main sources we identified were interpersonal, so poor relationships between people, poor communication within teams, disagreements on how to perform tasks or how to care for patients. And then one that really intrigued us was social representation, because a lot of people told us about conflicts and frustrations they were experiencing, not with one single person, but with a whole group. And it didn't really matter who the people in that group were. And they actually were not even in conflict with the individual members of that group, but they were just in conflict with the whole group. And that could really create some tension and some resentment over time. And so that's, for example, when some residents would tell us that nurses tended to ignore their orders or not consider them as knowledgeable. And so after a while, the residents would be like, well, all nurses don't really consider us. Or a lot of supervisors would tell us that, oh, the residents, they don't work as hard as we did. And that, like, they recognize that individual residents worked really hard, but as a whole, the residents were perceived to not work as hard as the supervisors had when they were in residency. And so they thought that that wasn't fair, and just led to some frustrations. So all these different factors could trigger conflicts that had consequences on individuals' well-being and just personal consequences on people. It also impacted their careers and just led some people to leaving their institutions or changing team or changing specialty. It affected teams, obviously, and just institutions, and all that impacted patient care. There's different strategies for managing conflict that have been described in the literature, but what we found was that some people tended to impose their decision and just say, okay, we'll just do it my way, and not really have a discussion about it. But most people we interviewed talked more about how they avoided conflicts. They were not comfortable talking about it or addressing them. And some people also yielded and would just say, okay, we'll do it your way. And that meant that we didn't really get those positive effects of conflicts that we know we can have. So there was no discussion about why a decision was being made, which then meant that, again, it built up resentment over time. And very rarely did people actually sit down at the table and address the conflict and try to find a solution and solve the problem. So all that really told us that conflicts are problematic because they're not addressed, and that leads to more conflict. So it's just a vicious cycle. Something else that we identified through our study was that supervisors were almost always involved one way or another. Sometimes they were perceived to be the party and the other party in the conflict, but a lot of times they were involved in a different way, in that people who were experiencing a conflict had gone to their supervisor asking for support or help, and the supervisors didn't really react the way that people were hoping they would. That could be because supervisors, sometimes they just didn't feel equipped to handle the conflict or didn't know what to do. Sometimes they did something, but that wasn't what the participants were expecting. And so there was a lot of dissatisfaction with the supervisors and how they helped or did not help manage the conflicts. And because of this really important role that supervisors had in conflicts, we decided to look a little bit more deeply at how power dynamics and hierarchies play out in conflicts. To do that, we used what's called the social basis of power, which is a theoretical perspective that describes different sources of power that people can draw from. The first one is probably the one that we all know. It's called positional power. And it's basically power that we draw from having a specific position in the hierarchy or a specific title. The next source of power that people can draw from is expert power. So that's basically expertise or experience. So a lot of people may not have a lot of positional power, but they have worked at an institution for so long that they get a lot of expert power. The next one is informational power, which is power that we can draw from having information. So for example, a lot of nurses can have informational power because they spend a lot of time at the bedside, which really gives them a lot of information about how patients are doing during the day, what families are talking about, what the family's concerns are, and then they can take that information to the rest of the team and really use that information to negotiate for specific approaches to patient care, for example. The next one is reward power, which is basically the power that people have when they can offer benefits in exchange for compliance. So that's supervisors tend to have a lot of reward power because they can write recommendation letters, they give evaluations, they give feedback. So all that gives them reward power. Coercive power is the ability to force people to act in a specific way, and referent power is power that people can draw from by inspiring warmth and confidence. So it's basically charisma, or making people feel like they want to be you or they want to help you. So based on that, we looked in our data to see how power was involved in conflict stories. And for that, we used all our data from the US, Switzerland, and Hungary. And what we found is that even though these are very different places with very different cultures and very different approaches to power dynamics, for example, Hungary was in the USSR, and so they just have such a different history. And despite all these important differences between the sites, actually the sources of power that were involved in conflicts were very similar across sites. And the conflict stories that involved these sources of power were very similar. So the main source of power involved in conflicts was positional power, and it happened in conflicts, or it came up in conflicts when learners perceived that their supervisors had used their higher status inappropriately to enforce a decision, for example. It also happened in conflicts between physicians and other members of the team, because physicians sometimes were perceived as just having used their team leader position to enforce their decisions without really listening to other people on the team. Expert power was the second most common source of power involved in conflicts, and it was involved in conflicts very often between professionals from different specialties. So that could be, for example, between the ICU and internal medicine, or the emergency room and internal medicine, when basically people were trying to move patients around. And then there were really some conflicts that involved expertise and expert power in deciding who gets to decide where the patient goes, and who has the most expertise to decide where the patient goes. These conflicts also tended to happen between really experienced nurses and other healthcare professionals with less experience, such as residents, because the nurses had a lot of expert power and the residents had positional power, and just the intersection of those two types of power was difficult to navigate. And then finally, coercive power was the third biggest source of power used in conflicts. And that type of power was basically involved in conflicts between people and their supervisors around shifts and time off. For example, when people wanted to take time off for the holidays, but their supervisors didn't let them, that was really perceived as a misuse of coercive power. And then we also had a lot of conflicts with that type of power in operating rooms, specifically during surgeries, because at that time, the surgeons were perceived to have the power to just force people to stay in the room. And that also generated some conflicts. But through this investigation, we noticed that power is important, but much more, like all these conflicts that involved power actually involved different social groups. And we decided to try and understand that a little bit deeper even. And to do that, we used what's called the social identity perspective, which was developed by two social psychologists who were really interested in trying to understand racism and prejudice and discrimination. And so they developed this perspective to really try and understand relationships between different social groups. I'm sure you've heard some of the language associated with the social identity perspective, because the premise of that perspective is that people self-categorize into what is called in-groups. So for example, me as a postdoc in sociology at UCSF, I identify with I see UCSF as one of my in-groups. I see the postdocs as another one of my in-groups, and I have all these different in-groups that I see myself as being part of. And then, so we have our in-groups and we have the out-groups, who are the other groups. And for example, I'm not a clinician, so I don't identify with the clinician group. So for me, that's an out-group. And basically, according to the social identity perspective, people tend to view their in-groups as positive, and that means that in comparison, the out-groups are not seen as positive as the in-groups. And some groups are just groups that we're born into, but other groups, and especially the professional groups, it takes a lot of work to become part of those in-groups. And so when we finally become part of the in-group, we want to maintain the in-group because it was so hard for us to get in there. We want to maintain that positive image and that special status of that in-group, which means that people sort of engage in efforts to maintain the in-group, and that just creates distance with the out-groups that can, over time, lead to bias and discrimination. So we used that theory to try and understand those group dynamics that we were observing in conflict stories between professionals. And what we found is that group boundaries play out in conflicts in two main ways. The first is through processes of professional identity development and group membership, which basically means that because clinicians have to work so hard and go through so many steps to become the healthcare professionals that they want to become, such as, for example, a pediatric critical care physician, there's just a really long journey to being able to call yourself with that title and having other people recognize you as that. And that whole process is difficult. And when people finally get there, sometimes they feel like they're not really welcome into the group. And that really created a lot of conflicts. So for example, a lot of our participants reported that they didn't really feel, they ticked all the boxes to be part of the in-group, but they still didn't really feel like members of the group because they felt like they didn't speak the right language or had the wrong accent or had the wrong gender, and they just felt different from the rest of the group and not really welcome into the group, or like their membership into the group was questioned, even though they knew that they absolutely deserved to be a part of the group. So that really created some conflicts. And then another way in which group processes were linked with conflicts was just through power differentials between the different groups, because since each group tries to maintain its status, it basically tries to show that it has more power than the other groups, and that just creates boundaries between different groups. And that's all a little bit theoretical. So I added a quote just to give you an idea of what we mean by that. So one of the fellows in surgery was telling me about a conflict with another fellow who had basically mistreated trainees, but that first fellow who was talking to me said he didn't do anything about it, even though he thought it was completely inappropriate. And the way he explained it was, he said, well, we were at morning report, there were lots of people there, anesthesiologists, midwives, nurses, residents, students. And that's not the right time to discuss a colleague's attitude. We cannot start arguing at morning reports because, you see, out of respect for my colleague, I cannot start complaining about him. I can't say anything if there's a nurse with us. So basically, that person really wanted to save the whole group or save the face of his own group against other people. They didn't want the other people from out groups to be aware of internal conflicts within their surgery group. So that's one example. And then these conflicts were highly problematic because they could have fairly bad consequences on people. They could lead people to having self-doubt or to doubting their decisions, their competence. It could also lead to disillusionment and over time, just to the development of negative perceptions of other groups. So what we learned from all these studies on conflicts is that conflicts basically are cyclical processes, and they tend to lead to further conflicts unless we address them. intergroup boundaries, so boundaries between different social groups, involve power differentials and can lead to conflicts and are really intertwined with conflicts. And then failure to address conflicts can lead to stronger boundaries between different groups. And we don't want to have any of that happen. So what we can do about this, and we're working on it, one of the things that we realized is that that social identity perspective really helps us understand these problems between different social groups, but it also hopefully offers us some solutions or a way to think about solutions at least. And recently we wrote a critical review of published articles on bias and social groups in medical education. And based on these articles, we identified three main ways in which we think that hopefully looking at these intergroup dynamics through social identities can help us move forward and address these group boundaries and conflicts. The first one is equipping individuals with skills to reflect upon their own and others people's social identities. So just helping people become more aware of what their social identities are, which groups they identify with, and realize that at any given time, they identify with multiple different groups. It's just that one group may be more important than the others. The second solution or idea that we proposed was fostering in-group cohesion, and that can be done in different ways, mostly by trying to have bigger in-groups. So for example, moving from the small profession-specific group to more of a identifying as a healthcare professional and identifying with the whole healthcare team instead of just with a small professional group. And that can be done through mentorship as well. For example, if people in the group mentor more junior people in the group, this makes people feel more welcome and just creates stronger ties within the group. And the third strategy that we proposed was addressing intergroup boundaries, and that can be done through strategies such as allyship, when members of one in-group really become advocates for a different social groups, or conflict management or perspective taking, when really members of one group really try to understand the perspective of the other group. And we decided to try and implement some of that in an existing platform, which was the mock-code program at the Children's Hospital here. I'm sure a lot of you are familiar with the program, but just as a reminder, it's a program that has bi-monthly sessions, so every other Friday morning. At each session, there's 4 trained facilitators, 2 physician facilitators and 2 nurse facilitators, and about 20 participants. And it typically happens first as a pre-briefing that's about 5 to 10 minutes. And during that time, the facilitators basically orient the participants to the simulation session, explain what the session is about, what the goals are, explain some of the equipment, just getting everyone to feel familiar with the environment. Then participants do one scenario. Then there's an interprofessional debriefing that's about 20 minutes. Then there's a second scenario for participants to get a chance to practice again, and this time hopefully feel a little bit less stressed. Then there's a second interprofessional debriefing that's about 15 to 20 minutes again. And then typically the nurses stay for an additional hour-long nurse debriefing where they go through some of their equipment, some of their procedures. And at each session, there's usually residents, nurses, and pharmacists that come. And just to give a little bit more background on the mock-code program, it's an interprofessional simulation-based team training program. Interprofessional simulation. Yes. Sorry. Interprofessional simulation is a form of interprofessional education, which can be defined as health professionals from 2 or more backgrounds learning with, from, and about each other. So we tend to think about the with part where we put people in the same room, but learning from each other and about each other is just as important. And it basically seems to us like the perfect platform to try and foster in-group cohesion within the group of participants and facilitators, and address intergroup boundaries. before we did anything with the program, we wanted to be really thoughtful about our approach. So we did another scoping review where this time we looked at published interprofessional simulation programs. And we ended up identifying 49 articles that described interprofessional simulation programs. What we found is that a lot of these programs really only paid limited attention to interprofessional learning, and instead they focused more on clinical skills, algorithmic communication, but really not so much learning about others and from others. The design of the programs actually did not really allow for much learning about and from others. And very often the outcomes of these programs really didn't focus on interprofessional competencies, which gave us a pretty limited idea of what these programs do and whether they actually enable learning from and about others. We also conducted an observational study, and this was led by Dr. Mindy Chu, where we observed 7 different interprofessional simulation programs in Northern California. And there again, through our own observations, we realized that a lot of programs don't favor interprofessional learning. And the reason, even though they want to, they often cannot because of different barriers that they have, such as a lack of buy-in, a lack of resources, a lack of outcomes measures, because they don't have many resources, and it's really hard to measure the impact of these programs. So they have a really hard time demonstrating that they actually improve teamwork and collaboration. So that just makes it really hard for these programs. And then a lot of times we also noticed that power discrepancies really played out between participants in the simulation programs and between facilitators and participants. We also looked at the mock code program here itself. And for this, Dr. Kate Robertson led a study on that, where we did some observations and again looked at power discrepancies. And we noticed that they especially impact conversations during the debriefing after interprofessional simulation. And what we mean by that is that a lot of the physician facilitators tended to take the lead, and the nurse facilitators would just stand there and assist with the equipment, but we're not really playing much of a role in the actual simulation. And they often didn't really share their perspective. And as a result of that, the debriefing tended to really focus on medical management and medical content, even though a lot of participants were nurses and were not necessarily very interested in that, or didn't really gain much from that. And we also noticed that a lot of feedback that was shared during those debriefings was very positive and tended to be shared intraprofessionally. So physician facilitator to residents, or sometimes nurse facilitators to nurses, but never interprofessionally. And it was very rare that people shared constructive feedback. So what we decided to try and really improve collaboration and foster a more collaborative approach was to retrain all the facilitators, because they were doing a fantastic job, but we saw an opportunity to do even better. So what we tried to promote was a much more collaborative and interprofessional approach to facilitation, which we hoped would just foster more of a group cohesion, and just instead of people identifying as physician facilitators or nurse facilitators, that they would just identify as facilitators and see each other as part of that same facilitator group. We also tried to make sure that they would focus more on teamwork and collaboration in the discussions. And we really tried to encourage learning about and from others for both facilitators and participants, and to make issues of hierarchy and power explicit, to really help and address those intergroup boundaries between the different groups involved in the simulation program. And to do that, Mindy Chu and Jenna Isaka provided a lot of training to all the facilitators. So all the facilitators went back through that training. And also we developed a facilitator guide that you don't have to read all this because it's really small. But the idea with the new facilitator guide is to really try and promote those principles that we had developed. And we did that, for example, by giving both nurse and physician facilitators specific roles and just specific topics that they each have to talk about. And it's very clear who is supposed to talk about what topic. Another thing that we did is we really added questions or examples of questions that they can use. They don't have to, but just to give them examples of words that they can use to really try and encourage participants to learn about and from each other and understand each other's perspectives. And we also explicitly address power and just have people talk about how power dynamics and just those different sources of power associated with different groups and their positions and their level of experience can really impact team dynamics. We're in the process of collecting data on this, so I don't have the final results, but our preliminary findings are that we've had really positive reactions to the new guidelines. We've observed that there's much more of a collaborative approach to facilitation. The debriefing focuses much more on teamwork and collaboration, but as always, we can always do better. So we would like to help people focus even more or promote even more learning about and from others. And just some people are really comfortable talking about power discrepancies or really know and understand how power impacts them, and other people are less familiar with it. So that's something we can still work on. In qualitative research, we use a lot of quotes to illustrate our findings. So I just selected a couple of quotes from facilitators that really reflect what we were trying to accomplish. So one facilitator said, "It was always awkward because it's talking about before we implemented those guidelines." So she said, "It seemed like the nurse facilitators would set up everything and take everything down, talking about the equipment, the mannequin, things like that. And then we, the physician facilitators, would just kind of breeze in and do the fun part and breeze out." So I think the guidelines are really helpful in creating space for there to be equal amounts of talking between the facilitators. And then I think that ultimately it will probably help create more of a space for there to be the same type of conversation between participants. And then a nurse facilitator said that she really likes how it's like trade-off of the nurse facilitator and MD facilitator. So it's more cohesive, like we're a whole team doing this together. I feel like it takes away some of those power dynamics that were addressed with the guidelines too, by just the fact that we're co-facilitating. I think it's really great. So that nurse really put her finger on exactly what we were trying to do, which was create more of a sense of a cohesive team of facilitators that work together to facilitate the whole session instead of having one group that's leading and one group that's assisting. And that I also just wanted to say that wasn't necessarily because one group was really taking over. Sometimes the nurse facilitators just didn't know what to say or didn't feel like they knew what to comment on or had the expertise to comment on things. So just having those explicit roles, really feeling included, explicitly included in the facilitator team really changed a lot for them. Just a couple of concluding comments. Basically, I hope that I've shown that by focusing on the social identity perspective, it really helps us move away from trying to fix individuals and thinking more about group dynamics, and that's really helpful. Interventions that try to address those boundaries between different social groups can create more cohesion, as we just saw with that quote from the nurse facilitator, where it created a more cohesive facilitator team, regardless of the professional identity that they have. And then it is those types of interventions start making it possible to sort of break that cycle of conflicts and reduce intergroup boundaries. And before I finish, I just wanted to thank the Department of Pediatrics Grand Rounds Committee for inviting me today to acknowledge and thank all the wonderful people that I've had the opportunity to work with through this work, especially Dr. Sandrine Van Schaik, and just mention that a lot of this work has been sponsored or funded by the postdoc fellowships I received from the Swiss National Science Foundation, by a research grant from the Agency for Healthcare Research and Quality, and by the Society of Directors of Research in Medical Education. I think that's it.
Thank you so much, Nike. That was really fabulous. And of course, I am fairly familiar with all your work, but it's really nice to see it all in the broader context of everything that you've done, and such a comprehensive and in-depth story that comes out. I'm gonna give it a moment to see if people have questions that come up in the Q&A. But maybe I can start by asking you, I'm of course very familiar what we're trying to do with the mock code program, but what kind of like practical tips would you have for just people in the audience, everyday life, to promote interprofessional collaboration and work?
Well, I think like we're trying to do in the mock code program, it's really trying, like, showing curiosity and trying to learn about where the other people come from with their ideas, or inviting people to speak, and not just saying, okay, but asking, why do you think that way? Why do you have this suggestion? Just showing more curiosity and trying to understand where the other people come from. That really helps with that learning about and from other people. Of course, we don't always have time, but yeah, I didn't really talk about this much, but we also, through this study, found that a lot of the problems with not addressing conflicts is that people are always so busy, and there's always witnesses all the time. So sometimes just at the end of the day, going back to the person and saying, sorry, I didn't have time to ask you questions about this, but just trying to have those conversations sometimes away from all these witnesses, because there's always so many people around when we work in healthcare that I think trying to have some of these conversations in a more private setting can be helpful.
And then Dr. Rachel Wattier asked, how do training systems in healthcare compare and contrast with other settings? And is there something we can learn from settings that do interprofessional collaboration well?
Can you read the question again?
Yes. So she's asking, how do training systems in healthcare compare and contrast with other settings, so outside of healthcare?
Okay.
And is there something we can learn from settings that do interprofessional collaboration well?
That's a great question. I have been really embedded ever since I started my PhD in training center or academic teaching hospitals. So I really have only that perspective, or I know much better what happens in those training institutions. I know that healthcare has, and we've talked about this, Sandrine, healthcare, especially the safety movement, really draws from other industries, other high-risk industries such as aviation. And that's been really helpful and really given us some language and tools to work with. I think it's also really helpful to think about what is, like, we can't just copy and paste. I think there has to be an adaptation. So I think we're at a stage now where we're trying to have those adaptations and think about what we can use from other industries that have been successful at implementing things like a safety checklist, and really trying to adapt that to our own environments. I hope that answers the question.
I think one of the things that resonates there with me, Nike, is the importance of adaptation rather than just copy and paste, which I think people say this oftentimes with the aviation industry, right? It's like, oh, we should just do that, but it's a very different type of work that you're dealing with, and a different set of problems that you're encountering. And it's actually interesting because I was talking to a pilot not too long ago, and he reminded me that the original name for crisis resource management in aviation was actually crew resource management, and we've really focused on the crises but not so much on the crew. So it's important to think about that.
Exactly.
Mindy Ju says, great presentation, is always so impressed with you and your work. Beyond individuals, what could institutions do to foster this type of collaborative environment intra and interprofessionally?
That's an excellent question. I mean, I think some things are already happening, so I don't know that I have a very insightful or original answer, but just things like the DEI trainings and things like that, they're not perfect, but they're one place to start, having just learning about other people, learning about other people's experiences. And just when I went, there were people from different departments, different professions, and we all were in the same room talking about something that we really care about. And I think that's really helpful to bridge those. We all have all our social identities, but just it's helpful to be in that context where we start talking about how we all have common experiences despite all these differences. So I think that's one avenue forward, or one context that institutions can really easily implement. It's all really, I don't know that I have a very good answer. I think it's really tricky because ideally we would have more interprofessional education, but I know that just takes so many resources and coordination and time that, and I think some of the skills for interprofessional work can be taught separately. You don't need to have all the students from the different professions in the same room, but you can start to teach conflict management or things, communication skills individually, and then put people in the same room once they're a little bit more comfortable and have practiced those skills a little bit already, just to sort of make it, move the burden away from trying to coordinate different programs. There's a really excellent paper by Elise Paradis and Cynthia Whitehead, Beyond the Lamppost, that talks about just trying to think about when it's appropriate to favor those interprofessional collaborative skills and at what level of training they need to happen.
So Rachel Wattier just says 100% agree, our setting is unique in many ways, like you're working on this important area. And then we have a question from Dr. McNamara. Thanks for this excellent presentation. Given the silos and hierarchies within hospital systems, based on your many interviews, do you have top tips for those who are in positions of power who successfully navigate conflict resolution?
Oh, that's a great question. I'm trying to think. I don't know, because as I've spent more time in this field and learned more, I also realize that it's really hard for the people that are in a position of power. I know a lot of leaders really try to create what's called leader inclusiveness, and to create some psychological safety, and just really try to be open and ask questions and be available, but they still have that position of leader, or that leadership position that immediately creates a distance, no matter how hard they try. And I've become more aware of that lately, and just also seeing people seeing how becoming in that leadership position, or moving up into that leadership position, just changes the dynamics within teams, where one person used to be equal to the others, and suddenly they get in a leadership position and they're not treated the same anymore. And that's just human nature, and I think that's really difficult. But yeah, trying to be inclusive and ask questions and show openness and show curiosity when people come up with suggestions is probably the most we can do as individuals.
Thank you. Brene Brown at the AAMC meeting last week gave a really great talk about brave leadership and humble leadership. And I think there's probably some lessons there too that help break down those barriers. Let's see, Elizabeth Rogers, Dr. Elizabeth Rogers says, thank you for this super presentation. And I think with that, we've come to the end of our Q&A, we're giving people 10 minutes of their day back, which is a testimony to how rich of a presentation you've been able to give in a very concise way. And I'm sure you've given people lots of lots of food for thought. So Mindy says, I would love to see conflict resolution as part of healthcare training. I think some people would say it should be conflict management, but yes, it's definitely something that
there is a little bit of that for the like undergraduate students as part of their interprofessional longitudinal sessions. There's one session that's on conflict management. So there's a little bit of that. It's a 2-hour session. So of course it's not enough, but at least it's a start. And I think before going to the session, they have to fill out a little questionnaire that tells them what tendencies they have for addressing conflicts. And that's like every time I teach that session, they're always really surprised and say that they've learned a lot about themselves. So that's a start.
Yeah, that's great. I didn't know that was happening. That's really fantastic. All right. Dr. Lelkes, that's an excellent presentation and excellent work. And I think that's now really the end of the Q&A. So again, Nike, thank you so much for sharing your work with us. And we look forward to ongoing collaborations and learning more on how we can collaborate all together. Everyone, thanks so much for joining today and have a good rest of your day. Bye-bye.
Thank you.